Hi, friends. In today's lecture, I will talk about the differentials and the management of someone who presents to the emergency department with an altered mental status. A very, very common presentation when it comes to people being brought to the emergency departments. And as an emergency physician of over a decade of experience, I can tell you that this it is important to have uh, it is important to have thought about all the possible differentials so that you do not miss out on something that is um, quite which may be either life threatening or may cause severe disability. So first of all, what do we mean by altered mental status? Now, the word itself is self explanatory, which means that someone who their mental status is altered or changed. It is not usual. So, it may present in different terminologies being described by either the ambulance crew who brings them or the patient's relatives who bring them. So, someone who brings the patient can say that, or the patient just presents in a state where, so the presentations could be described in different words, where there could be like drowsy, confused, stuporous, delirious, agitated, or maybe just unconscious, or just or the unusual behavior. So how do you approach these patients? So first of all, any of these patients who are presenting with um, altered mental status should be considered um, very sick patients, and they should all begin with the primary survey, because any problems in a primary survey means that we will do an A, B, C, D, E survey, because any problem in A, meaning airway, breathing, or circulation, can affect how the oxygen is supplied to the brain, or the blood circulation. So any compromise in A and B and C can affect how the oxygen that is mixed in the blood is getting supplied to the brain, and that can itself cause altered mental status. And so first, any patients who present like these, you should take them to a resuscitation bay and ensure that they have a primary survey. So you check that their airway, their breathing, and circulation is fine. Get vitals, their heart rate, blood pressure, oxygen levels, saturation levels, their respiratory rate, temperature. So get all these things, and now when you check for D, which is basically disability check, when you check for disability, you would look for any lateralizing signs. You would check the pupils, but in objectivity, what would be defined as altered mental status is any person who has a GCS less than 15, whether it is 14, 13, anything which is less than 15, or on a scale of AVPU, A meaning alert, but any person who is responding to voice or a painful stimuli, or just unresponsive, meaning they would be classified as altered mental status. So once you've done your primary survey, and while you are assessing their doing the disability check, move on to your exposure, and but thereafter that the you would want to get some more information, and which in most of the life support courses we learn that there we get a quick history by taking the sample history, which is the signs and the symptoms. The signs and the symptoms reported as any signs that you've observed in your primary survey, or the symptoms that the patient reports of or presents with. A, any allergies, and M, their current medications, and their P is past medical history of note, and their last meal or last. Also, I take history of last past urine and last open bowels and things. And a very important thing is events. So what were the events uh, of the presentation that has concerned either the patient, their relatives, or the ambulance or the paramedic crew? So whether somebody collapsed for a little while or somebody, what was their behavior? So try to get as much detail from that point, that presentation, so that you can establish with as much clarity as to what was the onset, where, what was the situation like, where was the patient, what was he doing at that point, and then how long did this situation last for, what was done, any intervention that were done, and the entire journey from that point to the point of crisis to coming to the hospital should be clear in your E. So once you've established and got a picture there, now you're thinking what could be. And now here I will talk about a very nice acronym that I've come across in my learning of emergency medicine. And if you remember this acronym, it is a very comprehensive list, possibly takes you to a large number of differentials. But if you have a structure, it will ensure that you're not missing out on any. So remember this: AEIOU TIPS. So vowels, tips. AEIOU tips. That is how you could remember this. Now A, what does A stand for? A for alcohol, and consider acidosis. Now, so alcohol, when you think of it, could be the person has taken alcohol, or it could be alcohol withdrawal symptoms. Then E, electrolytes. So electrolytes, think of hypernatremia, hypercalcemia, so dehydration, and consider fluids and electrolyte status here. Consider endocrine, thyroid status, things like Addison's may cause issues, so electrolyte and endocrine. And then you come on to I, and I think of insulin, and when you think of insulin, think of glucose, think of their intake of food and water, how it has been. And then you come to O, think oxygen. So whether it is a case of hypoxemia or maybe a case of hypercarbia, so type 1 or type 2 respiratory failure, or is it a case of some sort of overdose that we are thinking of? Then you come to U. Now think of uremia, think of urinary retention. Now, and then you come to T. So there are multiple things in T. Think of trauma, whether a head injury has happened, temperature, is the patient hyperthermic, hypothermic, because either things can cause an altered mental status. Then think possibly a tumor. Think, is this relating to any toxidrome in the patient? Now, coming to I, this time think of all the infection, whether it is a generalized infection, whether it is a CNS infection, a meningitis, encephalitis, sepsis. And then, of course, you need to think of cardiac causes and think of ischemia. Now, once you've thought of this, coming to P, think of psychiatric, think of poisons, think of polypharmacy. So, this, once you've thought of this, go on to S. Of course, if somebody is coming in shock, that could be an ABC issue. But then shock, whether cause of whatever type, and then any of these causes could be when then you think of seizure, stroke, a case of subarachnoid hemorrhage, and a space occupying lesion. So this, in summary, will help you streamline your approach for any patient who's coming to the emergency department with an altered mental status. So that's it from me, and we'll see you in our further lectures. Any doubts or questions, I'll be happy to answer. Write them down in comments, and wait for more and think if you have any, and let me know if you have any further good ideas to share about this. Thank you.